Respected Professor. Yes, please, sir. Good evening, respected Professor and dear students. I welcome you all to another session of RAISA DNB online academic activities today. Today we have something related with artificial reproduction technology and fetal surgery case presentation by MEOD students. Over to Professor and MEOD students, please.
Okay. We have a major case presentation first. 15-year-old girl coming with a progressively deformed back. All of you should have made a diagnosis because diagnosis is not clearly given here. So, what is the diagnosis of that case summary given in the first question?
Scoliosis, sir.
Scoliosis. Okay.
Yes.
So, who is going to present that?
Myself, sir, Dr. Shovika.
Shobhita. Okay. So, I will just go to the screen to show the questions.
Okay, sir.
Is it visible now?
Yes, sir.
Yes, sir.
So this is a case summary given here. 15-year-old girl with progressive deformity of her back, making her left shoulder tilt downwards. That means the right shoulder is tilted upwards. Identified to have a bob angle of 60 degrees, posted for corrective surgery. Discuss the anesthetic management. So this sort of case scenario may be given in your theory question paper also, as well as your viva. Or if you have a live patient with scoliosis, they may show you this patient also. The first question is, what is the condition called?
Scoliosis, sir.
So scoliosis. What are the causes of this condition?
Sir, it could be idiopathic or congenital, sir, or
Hmm.
could be acquired.
Hmm.
Idiopathic could be due to patterns or central nervous system dysfunction, sir. Congenital, it could be due to an insult during intrauterine life associated with congenital abnormalities, either cardiac or urinary. And acquired, it could be due to trauma, any vertebral tumors, sir, or neuromuscular causes like CP, cerebral palsy, muscular dystrophy. And then it could also be due to mesenchymal disorders or neurofibromatosis.
Okay. Define scoliosis and the sites of its occurrence.
Yes, sir.
How will you define scoliosis?
Scoliosis is a lateral curvature of the spine greater than 10 degree as measured by Cobb's method, sir. Depending on the region, it could be cervicothoracic, thoracic, thoracolumbar, lumbar, and combined double primary, sir.
Okay. Cervical, cervicothoracic, thoracoid, lumbar, and lumbar alone. So it can be isolated in one region, or it may be a combined occurrence in the all the regions of the spine. Which is the most common type of scoliosis?
Thoracolumbar, sir.
And among the etiological causes?
Idiopathic is the most common, sir.
Adult
70%.
idiopathic AI scoliosis, AAC as it is called.
Yes, sir.
How is the severity assessed and why that assessment is important?
Sir, severity is assessed by Cobb's method, sir.
Measuring the
it is
Cobb's angle.
Cobb's angle, yes, sir.
Hmm.
It is important to prevent the progression of the curvature and to prevent the further worsening of cardiopulmonary functions if it is already exists.
Very good. So the more the curvature, which system will get affected? How do you say cardiopulmonary? What are the effects on the cardiopulmonary system if the curvature is too much?
Sir, pulmonary system, there will be restrictive pattern in scoliosis, sir. So there will be decreased.
Depends upon the angle. Is there any criteria to say that this much affection will be there?
Yes, sir.
What is the angle
Yes, sir.
which will cause the maximum effect?
Maximum effect with the greater than 60 degrees, sir. Greater than 40 degree will go for surgical correction, sir. Greater than 60, severe pulmonary complaints will be affected, sir.
What about 100, 110, 120 like that? Is life
Yes, sir.
possible if it is 120?
Yes, sir. With 120, there will be chronic respiratory failure, sir.
Survival
That
will be
will-
very difficult.
Yes,
So
sir.
that will be corrected at the earliest benefit. So what are the effects of this on the various systems?
Sir,
Again, the
on
same question. Individually,
okay,
you must describe what is the effect on the cardiovascular system, effect on respiratory system, effect
Okay.
on neurological system. Like that you must describe individual system effects.
Okay, sir. Sir, in respiratory systems wise, there will be reduced lung volume, reduced vital capacity. Due to the abnormal thoracic geometry, there will be a marked decrease in chest wall compliance, sir, which will result in increased work of breathing. Patient usually have restrictive pattern. There might also be obstructive pattern association also. And there will be a increased pulmonary vascular resistance, sir, which might lead to pulmonary artery hypertension secondary to chronic hypoxemia. There could also be ventilation perfusion mismatch, sir. In CVS wise, due to the pulmonary artery hypotension, patient might go in for right ventricular failure, sir. And scoliosis might also be associated with congenital heart disease, mainly mitral valve regurgitation. And neurological wise, patient might have focal neurological deficits, sir. So it is medical legally we should document if there is any focal neurological deficit beforehand.
Is there any other effect on the other systems like renal, hepatic?
Yes, sir. In hepatic, due to the right ventricular failure, there might be congestion of liver also, sir. So hepatic system. Renal, there might be hypoperfusion to the renal circulation, sir.
All that is due to secondary to cardiovascular.
Cardiovascular. Yes, sir.
So severe cardiovascular affection can produce its effect on the hepatobiliary as well as the renal system.
Yes, sir. Yes, sir.
What are the important points to be obtained in the history of the patient?
Important points. Initially, we'll ask for the presenting complaints, sir. When was the deformity, onset of the deformity, progression, and if there is any neurological problems like gait problems, loss of balance, and history of breathing difficulty, frequent respiratory tract infection, whether the patient have breathlessness on exertion, a palpitation, swelling of lower limb, if there is any previous history of seizures, and any urine or fecal incontinence. And we should also ask about old records of any images, and if there is any previous intervention was done, like bracing or past surgical correction was done. So we can also ask about pains if it is associated with tenderness.
Is there any possibility of malignant hyperthermia in these patients?
Yes, sir. Mostly scoliosis associated with neuromuscular disorders, sir. So they will be prone for malignant hyperthermia, sir.
So how will you elicit whether this patient coming for surgery may have this problem?
We can elicit from family history, sir. If any siblings or any of the family members have a previous history or are affected by any neuromuscular disorders.
So that is the only way to ask. Okay. Otherwise,
Yes,
is
sir.
there any test to rule out the possibility of malignant hyperthermia? Can you do any pre-anesthetic checks to rule out malignant hyperthermia in a patient whom you can suspect there is a positive family history? Supposing the parent gives that somebody else in the family had a surgery, then post-op they had developed high fever, because that is how the thing will be described to the patient's relatives. Patient developed high
Yes.
fever and collapsed. That is the history, and this patient is a sibling of that particular patient. Is there
Yes,
any
sir.
test by which you can find out that they are also going to suffer from the same malignant hypothermia problem?
Biopsy only was available, sir. Muscle
What
biopsy.
biopsy?
Muscle.
Muscle
Muscle
biopsy.
biopsy and doing a caffeine halothane test.
Caffeine test is, sir.
Caffeine halothane test is the only method of proving that they are likely to have malignant hypothermia. Supposing
Yes.
it is positive and they need correction also, how will you manage that patient who is prone for malignant hypothermia?
Patient was susceptible for malignant hypothermia. I will avoid succinyl colon, sir, intraoperatively.
Very good. Then what other things to avoid?
Halothane also. Halothane.
Mostly all volatiles should be
All
avoided.
volatile anesthetic. Yes, sir. Halothane
Yes,
sevoflurane.
okay. So
Yes,
dextromethonium and volatile anesthetic agents are the two notorious agents to trigger the malignant
malignant
hypothermia. So
hypothermia.
if you have a suspicion, avoid dextromethonium and avoid all volatile. So avoiding volatile, how can you maintain anesthesia?
Intravenous agents like
Very good.
propofol,
Go for total
dexmedetomidine.
intravenous anesthesia or TCI, total target controlled infusion.
Infusion.
Okay, these are the availability of total intravenous anesthesia is the option or choice for patients with malignant hyperthermia. Okay, so this may be the supplementary question that you may get from this. Any history you are taking, but there is a possibility of MH, you must know these few points. Okay. Are you all able to see the slides? Are you seeing the screen?
No, sir.
You're not seeing? Huh? You're not
No,
seeing?
sir, not visible, sir.
Not visible?
Yes,
No,
sir.
sir.
See, sharing is stopped, sir.
I thought. Oh, and then. Is it visible now?
Yes, sir.
Okay.
Loading, sir.
So what are the important physical findings we have to elicit in this case?
The physical findings, spine examination, head to toe examination, neurological examination, sir. In head to toe examination, I'll check for the position of the head, whether it is central, and then any abnormality of the face, eyes, ears, nose, and mouth and oral cavity should be examined, and chest symmetry should be checked. So mostly it will be asymmetrical, and shoulder symmetry, sir. And if there is any prominent scapular ribs and margins of the trunk, which will be usually asymmetrical, and external genitalia and skin like café spots if the patient is a neurofibromatosis case, and extremities for any limb discrepancy, sir. And then we can look for gait, sir, any gait abnormality. In the spine convexity, pelvic asymmetry, sir, range of motion and flexibility, and decompensation head and trunk, sir, and then posture, sir.
Posture. So you must examine the patient from the front, from the back, and also
Back, yes,
what
sir.
is Adams forward bending test?
Sir, it is to detect whether the patient has got structural or a functional scoliosis, sir. We should ask the patient to stand with the feet and knees together and bend forward with the palms facing each other. And we should examine from behind, side, and front. We should look for any asymmetry, rib hump or lumbar prominences. If it is a structural scoliosis, the scoliosis remain the same as in standing position. If it is a functional scoliosis, the abnormality becomes more prominent. Sir.
So what are the pre-op investigations needed in this case?
Sir, I'll ask for routine CBC, sir, HB, total count, differential count, again, blood grouping, viral markers, coagulation profile, LFT, RFT, and then special investigations like pulmonary function test, then ECG echo, sir, and ABG if needed.
So X-ray spine and measurement of the angle, all these things would have been done by either the Toki or the
Surgeon.
right?
Yes.
The surgeons who is going to operate.
Yes.
Any pre-op preparations needed in these patients?
Yes, sir. We should prepare the patient both physiologically, if there is going to be a wake-up test, sir. Physiologically, we should encourage the patient to do incentive spirometry, breathing exercises, and to encourage coughing. If there is any underlying obstructive lung disease, we'll give bronchodilator therapy, sir. Psychologically, we should explain to both the patient and the parents regarding the wake-up test. We should emphasize that the patient may be awake, but they won't feel any pain during the procedure, and they won't remember the event post-operatively. And we should also explain about the post-operative ventilation.
Is there any preparation needed to consult with the surgeon or discuss with the surgeon?
Preparations regarding blood loss.
One regarding blood replacement. Second is regarding neuromonitoring. Do you have to discuss?
Yes, sir.
You must ask the surgeon whether they are going to employ intraoperative neuromonitoring. In what way that is important to ask the surgeon whether you are going to do intraoperative neuromonitoring.
So that if there is intraoperative neuromonitoring, if wake-up test means we can prepare the patient, sir. For the neuromuscular monitoring,
neuromuscular monitoring we don't do.
Yes,
Neurological
evoked
assessment.
potentials.
We want to do evoked potential monitoring.
Evoked potentials, yes, sir.
Photosensory evoked potential and motor evoked potential monitoring. The
Yes,
surgeon says, yes, I am going to do those two tests intraoperatively to assess the neurological damage that can possibly happen during intraoperative period. What are you going to do? What way you have to prepare yourself for that particular type of monitoring?
Yes, if there is a neuromonitoring, I will avoid a neuromuscular blocking agent, sir.
Very good.
And I'll try to avoid inhalational agents, sir. If required, I'll keep it less than 0.5 max, sir. Usually, I'll go with the TIV as a total intravenous anesthesia.
Yes. So that is how your anesthetic plan has to be modified if the surgeon insists on going for sensory evoked or motor evoked potential neuromonitoring intraoperatively. So that also comes as a part of preparation. So the preparations can be with the patient and with the surgeon, consulting the surgeon and deciding what type of anesthesia to give. So what plan can be made for intraoperative blood replacement?
For intraoperative blood replacement, we can go for autologous transfusion, sir, and isovolemic monovolemic hemodilution, and then autologous transfusion, sir.
Autologous transfusion means transfusion of blood from the same species, human species.
Salvage.
But what about pre-op donation? Does it come under this category? No,
yes,
normovolemic acute dilatation is done on the day of surgery. But in the pre-operative period itself, supposing the patient's hemoglobin is 15 grams for this girl,
yes,
can you bleed and keep her blood at some interval and restore it and use it when there is a need for replacement?
Yes, sir. We can. Autologous blood transfusion, sir.
No, autologous transfusion is transfusing blood from any other human individual. I mean, from the same patient, but it is called preoperative donation.
Okay.
Okay,
Sir.
by the say, patient himself donating, it's called preoperative autologous donation. You store
Okay,
that
sir.
blood and utilize it intraoperatively. That is the first possibility. The second possibility is acute normovolemic hemodilution technique, where you bleed the patient on the day of surgery on the OT table and then replace. How do you do the acute normovolemic hemodilution? What is the method of doing it?
Sir, we'll collect the
How
blood
much blood you can bleed
pre-operative.
on the table and how much you will replace with what?
Around 300 to 500 of blood can be collected, sir.
Very
And
good.
the blood volume is replaced with crystalloids or colloids, sir.
How much?
1:3, sir. As in for 1 ml of blood, 3 ml of crystalloid should be replaced.
So it can be either 1:3 crystalloid or 1:1 colloid.
1 colloid, yes, sir.
So that is how you do that. That is the second method. Any other method?
Salvage transfusion, sir. Like the blood
Intraoperative cell salvage.
salvage.
Okay,
Yes,
whatever blood is lost during the intraoperative period, that can be collected, washed, and reinfused to the patient on the table. Okay, that is the third method. So this is
Yes.
this method is this question can be asked in the theory exam also. What are the
Yes.
methods of conserving blood loss in major spine surgery or management of major blood loss during spine surgery? You have to answer these three methods. One is pre-op donation. Second is acute normovolemic hemodilution. Third is intraoperative cell salvage. Okay? These are the three things. And in which particular patients these techniques will be very useful?
In patients where we expect more than 20% of blood loss, sir.
Okay.
More than 1 liter of blood loss, major blood loss.
Okay. That's the only criteria. Is AB negative group very commonly available?
No, sir. Rare blood group patients also.
So that is the first answer. In patients who
Okay.
have a rare blood group and availability of donor blood from other external sources is not feasible, then the patient himself can donate, or you can do an acute normovolemic dilution on the day of surgery, or you can use cell salvage. So it is very, very useful in patients with rare blood groups where the obtaining blood will be a difficult process. So in order to save the blood from them is much more easier. Okay?
Yes, sir.
What is a wake-up test and how do you counsel the patient for this? Of course, you have answered all that. So exactly how do you do the wake-up test? You
Sir,
have
wake-up
done the
test.
counseling. You have told what
Yes.
points you have told already is sufficient to tell the patient that you will be made awake during the surgery and you will be asked to do something, but you won't have pain and all that you have told. But how exactly do you practically do this test?
Sir, I will lighten the intraoperative anesthesia, sir. And
First, you must
once I
ask the
make
surgeon what time he wants to do the picture, isn't it? You cannot lighten the pain at any time you like. So you must
Yes.
have a good understanding and discussion with the surgeon and ask him when he wants to do the wake-up test so that you can time
Yes.
your lightening the anesthesia plane. Isn't it?
Yes, sir.
That is the first
Yes,
point you
sir.
must say. Okay.
Okay,
So
sir.
surgeon has said in another 20 minutes I want to do the wake-up test because I have done the maximum stretching of the spinal cord. I would like to see the conduction being intact or not. So
Yes, sir.
he gives you 20 minutes time. What will you do?
Yes, sir. After lightening the plane of anesthesia, once I make
Hmm.
sure the patient is awake and able to follow the commands, the patient will ask the surgeon will ask the patient to wriggle his toes, and if the
Surgeon
patient,
will ask or you will tell the patient.
I will tell the patient.
You are at the head end. So
Yes,
you
sir.
only have to tell the patient that you can dorsiflex your foot or bend
Yes,
your
sir.
toes Whatever
Yes, sir.
instruction, you should have told that thing to the patient pre-operatively also. Intraoperatively, I will lighten the pain, make you become conscious, and I will ask you to do some movements that you have to carry out. So you can tell the patient that you can bend your toes or bend your ankle. And if the patient is able to do that, means the wake-up test is positive.
Positive. Yes, sir. And the patient will be put it back to
And
sleep,
the
sir.
muscular motor neurons are intact and not damaged. Who
Yes.
described this test?
Stagnara.
Stagnara. Which
Yes.
country he belongs to? Any idea?
Uh,
The European country, Spain. Okay.
Okay.
Describe the steps in anesthetizing the patient for scoliosis correction, the challenges and their management. Now, this 15-year-old girl, given in the history, she is accepted for the surgery. You have seen her pre-operatively, you have examined, you have done all the tests, and you find that she is fit enough for surgery. Blood is reserved. It is a thoracolumbar scoliosis, and the surgeon is, what is the usual surgery that is done for thoracolumbar scoliosis correction?
Spinal fusion and Harrington rod placement, sir.
Rod implantation. Very good. So that is the thing that has been planned. It will involve almost about 6 to 7 segments of the spinal vertebra. Okay, so that much of a dissection is going to be done. So the patient is starving because it's an elective surgery. Patient is brought wheeled into the theater. Have you done a scoliosis case?
Yes, sir, I have done.
Being MEOT students, all of you should be very familiar with, because mainly orthopedic hospital, and you have frequently seen a case like that. Now, can you enumerate all the steps that you will follow in anesthetizing this patient?
Yes, sir. My plan of anesthesia would be general anesthesia with flexible endotracheal tube intubation with controlled mechanical ventilation, sir. My plan is to induce the patient in trolley, sir, since it's a prone position. Once making sure I have a working suction machine and monitors, I'll secure a large bore IV cannula, sir, preferably 18 or 16 gauge. And then I'll induce the patient with Fent. I'll give anti-angiolysis.
Where do you want to place the cannula? Which part of the limb do you want to place the cannula? At the elbow?
No, sir. Not dominant hand, sir.
Non-dominant hand. It can be on the dorsum. It can be on the forearm. It can be at the level of elbow. Where do you want to place the cannula?
Dorsum of the hand, sir.
As distally as possible. Why?
Yes, sir. Sir, because the patient will be in prone position, sir. So
your access will be easier if it is distally placed, like in the dorsum of the hand. You can visually inspect the site as well as you can reach the site very easily under the ribs. Okay, so it is preferable to start the IV line on the dorsum of the hand, the non-dominant hand, where you can reach it easily. And any extravasation also can be easily made out if it is made on the dorsum, where you can visually inspect the site also. Okay, so that is the first one. Okay, you have started a large bore IV access. What about the monitors?
Yes,
will
sir.
You place the monitors now, or will you place it after the
before? Sir, I'll place the non-invasive BP and pulse ox, sir. ECG ideally on the back, sir. So that should be after the prone position, sir.
Prone position.
Yes, sir.
So unless the patient has any cardiac ailment preoperatively, ECG can be placed after proning the patient. Okay. Before that, a simple pulse oximetry and NIBP monitor will be sufficient for. When will you resort to invasive arterial BP monitor?
If the patient have any pre-existing cardiopulmonary impairments.
Okay. No,
or
this
in
15-year-old girl who has no cardiorespiratory issues, but very lengthy segment
long
exposure
segment.
and correction. Do you think the intra-arterial blood pressure monitoring is required?
Yes, sir, it will be required, sir, since we are
Why?
expecting major blood loss.
Major
during
blood
the
loss,
surgery.
one reason. Any other reason where IABP will be more safe and useful? Supposing surgeon says, I want less blood loss, can you reduce the BP? What is that
Oh,
anesthesia
for
for?
hypotensive anesthesia, sir.
So if you plan to do intraoperative hypotensive anesthesia to facilitate the surgical, reduce the surgical bleeding, then you have, if you have a IABP, you will know exactly what is the mean arterial pressure. So that why you want to know the mean arterial pressure rather than the systolic and diastolic?
Sir, for adequate, it will give us an idea of adequate perfusion, sir, cerebral renal
How do
perfusion.
you calculate the spinal cord perfusion pressure, SPCC?
With mean arterial pressure, sir. With mean arterial
Arterial pressure minus?
minus, I don't remember.
Minus CSF pressure. See,
Yes.
everywhere there is a surrounded by CSF. Just like cerebral perfusion pressure is MAP minus cerebral
ICP.
CSF pressure, it is the final mean arterial pressure minus the entire neurological system is dependent on that only. Okay, so it is
Yes, sir.
MAP minus CSF pressure is the spinal cord perfusion pressure here also. Okay, so
Yes, sir.
what is the ideal mean arterial pressure you should try to maintain?
55 to 65
65
millimeters of
millimeters
mercury.
of mercury. Very good. Okay. So lesser than that, what is the danger or what is the risk?
Sir, inadequate renal perfusion, sir, and decreased urinary output. And
The renal
inadequate
perfusion you are worried about in this surgery?
cerebral
Spinal
perfusion,
cord
sir.
ischemia.
The spinal cord ischemia also can affect the neurological function. Okay, even if there is no anatomical or physical damage to the spinal cord, a long-standing or a long duration spinal cord ischemia itself can affect the neurological function.
Yes, sir.
So to avoid that only, you want the liquid perfusion in the form of mean arterial film between 55 to 65, which will at the same time help the surgeon to have a very clear field without much of blood loss. Okay, right. So these are all about the monitoring before starting anesthesia. What is the next step after you have placed the monitors, you have secured the IV line? What is the next step in the conduct of anesthesia?
Inducing the patient, sir.
Always in the exam, if they ask you general anesthesia, what is the first thing you should never forget after IV line and monitoring?
Pre-oxygenation.
Never forget that. That is a very, very
Yes,
basic step. If you make a mistake on that, the examiners won't tolerate that. Okay, so
Yes.
never forget to mention about pre-oxygenation
Pre-oxygenation.
in all patients, whether they are young or old. Always mention pre-oxygenation. Okay, so pre-oxygenation for 3 minutes, especially in a
3 minutes.
scoliosis patient who may have a compromised restrictive lung function. Pre-oxygenation is very important. And if it is a upper thoracic and cervical scoliosis, what other problem you may have in addition to the respiratory restrictive function?
There might be a compromised trachea also, sir. So mechanical obstruction, difficulty in intubation.
Difficult airway. It be a difficult
Yes,
airway because the neck movements are also restricted. So the adequate positioning and adequate exposure of the larynx with the laryngoscope may be difficult. So if that has been the location and if you have made a diagnosis of difficult airway, how will you plan your anesthesia?
I'll make sure the difficult airway cart is ready, sir.
Excellent, very good. Then
And,
very good. But that's a very important first point. You must check that your difficult airway cart is well equipped and functionally ready. First
sir.
point, very good. Then what are the other things you should keep ready?
Fiber. Sir.
A good assistant.
In
In case you plan for
okay,
an
sir.
IV induction, relaxant, and then intubation, you must have good assistants to help you.
Yes, sir.
Or
Bougie.
if you have
Full and
made
bougie.
it impossible to induce and intubate, then you go for awake fiber optic intubation. Okay, so
Yes, sir.
these are the 3 points that you should always remember in difficult airway. I will keep the difficult airway card, check all the instruments, and keep them ready and functional. In case I want to induce and proceed with the attempted intubation, I will keep a very knowledgeable assistance or a
Assistance.
senior help for me to succeed in intubation. If it is an anticipated difficult airway, I will not attempt intubation after induction. I will straight away plan for a awake fiber
Awake
optic
fiber.
intubation under topical analgesia. These are the classical 3 answers expected out of you in the management of a difficult airway situation. Anticipated difficult airway. Right.
Yes.
Now this girl has got only a thoracolumbar and her airway is Malapati grade 2, not a difficult airway. So you go for how do you do the induction, how do you do the intubation?
Yes, sir.
What the induction agent you want to give?
Sir, I'll give anxiolytic midazolam, sir,
Very good.
0.05 mg per kg. And then I'll give fentanyl, sir, 2 mg per kg. Xylocard 1 to 1.5 mg per kg, sir. And I'll give propofol, induction agent propofol 2 mg per kg. Have mask ventilation, sir. If I can able to bag and mask ventilation,
Bag and
sir.
mask
Check
ventilation.
bag mask
Okay.
ventilation. Yes, sir. If I can able to ventilate, I'll give I'll prefer atracurium, sir, 0.5 mg per kg, intermediate acting.
Okay.
And
You don't want to give any anti-Silagop, like a protein or a
no, sir, we have to. We can
you
use
didn't mention. You
anti-asthma.
mentioned
Yes.
midazolam, straight away switched went to fentanyl and lidocaine propofol. You should never forget that you have to give anti-Silagog in this case. Why?
Sir, because we are putting a patient in prone position, sir, so there will be increased salivation. The plasters might get wet and there will be a risk of ET tube slippage, sir.
Very good. So any change in position, as long as the patient is supine, even if you don't give anti-Silagog, nothing will happen. Even if secretions are there, you can easily suck it out by suctioning the oral cavity. Whereas in the prone position, you won't have, first of all, access to the secretions. Second, these secretions will drool out and make the plasters wet and dislodge the tube. So you have to remember that you have to give glycopyrrolate also along with your midazolam before you give fentanyl, and then proceed with the regular action with lidocaine, propofol, atracurium, whatever you want to give. But if the patient, the surgeon says they want to do neuromonitoring, SSCP and MEP, giving atracurium and intubating the patient, is it okay?
No, sir.
No.
No, sir.
Why?
But the monitoring will take some time, sir. So since we are giving intermediate acting, by that time
I can give because it is not the within the first dose. They are not going to do the neuromonitoring. They will take at least 2 to 3 hours to come to the stage of neuromonitoring, isn't it? So by the time you can, your atracurium effect will be gone because it's only an intermediary acting drug. So for intubation, I can safely use atracurium. That should be your answer. Okay.
Yes, sir.
So these are all the steps in the induction. You said you will use a very particular type of tube. What type of tube you want to use?
Flexometallic tubes.
Flexometallic cupped orotracheal tube.
Cupped
oral flexometallic tube. That is the complete answer. Not just saying flexometallic will not be the correct answer. In the exam, they want you to do, describe the tube proto. So you have to say it will be a appropriate size cupped flexometallic tube. Why you want to use a flexometallic tube?
Sir, to prevent kinking, sir, and
Prone
RB since the
kinking.
patient, yes, sir. Since
Yeah,
you're putting the
because the
patient in
patient is
prone
going to be in
position.
prone position, you don't want
Yes.
any kinking to happen. And any special precaution you will take after you intubate and then secure the tube with a plaster? Normally, for a 15-year-old girl, what will be the length of the tube you will insert into the trachea and oral cavity?
For
18
much
to
of-
19 centimeters.
Roughly about 20 centimeters. Okay.
okay.
So a female patient, 15-year-old, roughly you will insert the tube between 18 to 20 centimeters. So it is always safe to mark that length at the plasters, on the plasters with a marker pen, so that
Okay.
when you turn the patient, you know whether the tube has slipped and come out. Okay. So if it is seen at 16 after turning the patient, that means the tube has slipped out a little bit more. So after you intubate and make sure that the air entry is equal on both sides, when you secure it with a plaster, have the habit of writing out the length at which that incisor level, the tube. So it will, this is a good habit to make sure that when the patient is turned prone, there is a possibility tube can slightly slip and come out. At that time, you will know, can push it back and secure it with another tape before you proceed. Otherwise, there are cases reported where tube has slipped out intraoperatively midway through, and a lot of chaos has happened. So it is always better to mark the length that has been introduced, where both sides adequately are ventilated. Right. So Flexa metallic tube is used, you have succeeded. Now, what are the steps in turning the patient to prone position? What is the support that you want to check before you turn the patient? Where are all the supports to be?
Sir, we need to make sure it, all the pressure points are padded, sir. In female patient, especially breast region, sir, upper chest, and elbow region, sir, knees.
More than
and
padding, what is the most important thing that you should take care when proning any patient?
Eyes.
you should pad the
Especially
groin,
for eye surgery. First and
groin
foremost,
region,
huh?
groin region, sir.
Groin.
Eyes.
Have you read
Yes, sir.
about groin, eye, first thing? The abdomen should be free. There is no
Yes, sir.
compression
Yes, sir.
should be applied to the abdomen. The support should not be pressing on the abdomen. There should be free movement of diaphragm. There you must be able to pass your hand between the patient's tummy and the operating table.
Yes, sir.
But in patients with huge points, this may not be possible. So you have to make the support little taller so that you will have some gap between the table and the abdomen. Okay. So
Yes,
first
sir.
and foremost thing is make sure that
Abdomen is
the
free.
supports are not impinging anywhere in the abdominal area to restrict the diaphragmatic movement, number one. What will happen if incorrectly placed support presses on the abdomen? What is the intraoperative problem because of that?
So there will be raised intra-abdominal pressure, sir, and then engorgement of epidural venous plexus, sir, and
Very
there will
good.
be
So
increased
the venous
bleeding, sir.
use will be more. If proper positioning is not done, intraoperative venous oozing from the epidural veins will become congested. Everywhere when the surgeon cuts, these veins will start oozing and there will be a diffuse ooze and blood loss will be more. So, right from that point of view also, both from anesthetic and surgical point of view, a proper positioning to have a pressure-free abdomen for free movement of diaphragm as well as preventing the pressure in the epidural veins is very, very important. Then, of course, you have to make sure that there are no pressure points compressed like elbow, eye, the ankle, the lateral peroneal nerve area. Everywhere you have to properly pat the patient and keep the patient. Of course, the groin also should not compress the major vessels like femoral vessels, and the uh, shoulder and the brachial plexus also should be taken care of. Okay, so
Yes,
these
sir.
are all the things. And after turning, usually you can apply your ECG electrodes also to monitor the ECG. Okay, right.
Yes, sir.
Now, from the skin incision, how do you provide analgesia for the surgery? What are the methods of providing analgesia for the surgery?
Yes, sir.
You have already given some fentanyl during
Opioids.
induction.
Yes, sir.
Ah.
We
Supposing
can give.
it is neuromonitoring is also planned. Then what are all the methods by which you can provide analgesia?
So Algesia, we can go for multimodal approach, sir. IV paracetamol, NSAID, sir, and opioids, as we have already said, and then block, spinal block, blocks, sir.
What block?
Erector spinae blocks, sir.
Erector spinae block can be instituted. Very good. How do you do the erector spinae block? To talk about erector spinae block, you must know how do you do that. Have you ever done that?
No.
No. Have you ever
No,
you
sir.
don't practice it in your institution?
No, sir, we don't practice.
You don't practice. So anyone else who knows at least the theoretical aspect of how to do an erector spinae block? Do you need any special equipment to do that?
Ultrasound guided.
Ultrasound guided. So ultrasound guided, what should you do? Have you ever read about this? One of the OSCE question, or it can be asked in the theory questions also. ESP Blake, erector spinae plane block, called ESP block nowadays.
Yes, sir.
So you must first identify the transverse process. Okay, it is just injecting the drug beneath the erector spinae muscle plane. Okay, so where is erector spinae? It is on the parallel to the vertebral bodies, isn't it? Transverse process is there.
Sir.
Lateral to the transverse process, about 2 centimeters laterally, you have the erector spinae muscle running from the head to cervical to the coccygeal sacral region. So what you have to do is identify the required level transverse process. But in this case of this is quite easy in a regular spine surgery like a discectomy or a laminectomy. But in a thoracic spine scoliosis, it may be difficult to identify the transverse process, and the muscles also may be little crooked. So instead of that, what is the easier method you can follow? Can follow any solution which can be large volumes injected into the operative area.
Tumescent anesthesia.
That is also one of the accepted techniques nowadays. Instead of going in for specific blocks which are difficult in scoliosis surgery, you can infiltrate tumescent local anesthesia liberally under the skin incision site as well as into the muscle plane, so that the blood vessels will be constricted and blood loss will be very minimal. At the same time, preservation of spinal cord blood flow will be nicely maintained. So, injecting the tumescent local anesthesia is also one of the additional methods to opioid-free anesthesia that you give for intraoperative pain loss, pain reduction. Right. So, how is the SSCP and the MEP done?
Sir,
So there is a question which is, are you able to see what is ankylosing test?
yes, sir.
What is that test? When do you do that? Have you heard of that?
Yes, sir. I heard of anesthesia.
Why do you want to do that ankylosing test?
For to detect motor integrity.
To check the integrity of motor nervous
Motor
system,
nervous.
you can do this. So after the surgeon has completed the surgery, when you want to check the motor integrity, what you can lighten the plane of anesthesia and dorsiflex the patient's foot. Then the patient's foot will go into clonic movements. Repetitive clonic movements will happen. This will happen even in normal patients. You can try it later, your
Okay, sir.
regular cases also. So all patients having an intact motor system, if you dorsiflex the foot, you will elicit the anti-clonus, which is a very simple, inexpensive method of assessing the integrity of motor nervous system. Now, how is SSP done and what is its important to anesthesia? Then what is
Sir,
SSP?
yes, sir. SSP also is to use to monitor the neural integrity, sir. Peripheral nerve is stimulated and the response is recorded in somatosensory cortex. Sir.
Very good. So, which are the common nerves which are chosen for stimulation? You should know the nerves which are commonly stimulated, no?
Yes, sir.
Which are the
Radial nerve, median nerve,
somatosensory evokopotential.
yes, sir.
Median
Median
nerve
nerve.
for spine surgery, what is the use? Select the nerve in the lower limb, isn't it? Because the spine surgery, especially thoracolumbar correction,
Yes,
involves
tibial
mostly
nerve.
tibial or the posterior tibial nerve is the ideal nerve. Okay?
Yes, sir.
And the motor evokopotential, how it is done?
Motor potential will be giving a transcranial cortical stimulation, sir. Responses are recorded in the peripheral muscle.
Peripheral muscle, very good. That much knowledge is here. So how do you diagnose and manage intraoperative venous air embolism? Is venous air embolism possibility is there in spinal surgery?
Yes, sir. It is possible, sir.
So which veins will suck in the air?
Epidural veins.
The epidural venous plexus. They are capable because of the negative pressure. They can suck in air and then they can absorb the air into the circulation. So, what are all the thirds of identifying venous
There will be
air
a
embolism?
sudden hypotension, sir,
Hmm.
and declining in ETCO2, sir.
Hmm. So, how do you manage that?
First, in the field, we'll ask them to flush the field with saline, sir.
Normal saline, very good.
Ask the surgeon, yes, sir.
Press the
And then,
veins.
and then we'll put the
You think like it is a worst air
patient.
embolism?
Yes, sir.
Unfortunately, a large quantity has been.
Yes. We'll put
You
the
have to
patient in
cover
head
the
down
wound.
position.
Can you treat it in this prone position?
No, sir.
No. So, in a very dire emergency, where a large quantity of air has been sucked in, it has gone as a major venous air embolism. You have to pack the wound with sterile drapes and turn the patient to
Patient in
supine
supine
lateral
position.
position to the
Yes,
left
sir.
lateral so that the right side will be up, and then treat it like a normal venous air embolism. And by removing air either by right atrial puncture or by a central canal.
To central venous line.
So these are the main methods that we do as we do for any air embolism. Now, how to minimize the blood loss during surgery? We have already seen some few.
Yes, yes,
Supposing the surgeon asks for hypotensive anesthesia, how will you provide hypotensive anesthesia?
sir. Hypotensive anesthesia through short-acting vasodilators, sir. Beta antagonist like esmolol, sodium nitroprusside, nitroglycerin, sir.
So, without using these drugs, is it possible to provide hypotensive anesthesia?
So to prevent the blood loss, we can use antifibrinolytic agents like tranexamic acid, sir.
But intraoperative hypertension anesthesia, first and foremost, you must maintain adequate depth of anesthesia. It is only inadequate depth and pain which will cause a catecholamine stimulation, which will result in tachycardia and hypertension, which will cause more bleeding. Okay, so a proper good depth of anesthesia itself is a good way of providing hypotensive anesthesia. But if you are using or if you are planning to do intraoperative neuromonitoring, then use of more than 1 mAc of volatile anesthetic agent may later on interfere with that. So in that situation, you cannot use the volatile anesthetics to cause some amount of cardiovascular depression to produce a hypertensive state. So there you have to depend on either you are not nitroglycerin or sodium nitroprusside, which are the drugs commonly used. Nowadays, use of dexmedetomidine also is able to provide some amount of hypertension. Okay, so by all these methods, you can provide hypertensive anesthesia, but with the caution that you maintain the mean arterial pressure around 60 millimeters of mercury to prevent ischemia.
Spinal cord ischemia.
So what is TRALI? How is it diagnosed if it happens intraoperatively, and how is it treated?
So TRALI is transfusion-related acute lung injury, sir.
Very good.
Patient will have ARDS pattern, sir.
Excellent.
Prone position and mechanical ventilation is the ideal treatment, sir.
Assuming the patient is in prone position.
Prone position and yes, sir.
When is the possibility? When which patient it is likely to happen? The word itself says transfusion-related acute lung injury.
Blood transfusion, yes, sir.
If you
other
are given more than 5 or 6 units of blood intraoperatively for a patient where extensive surgery is done, then you must keep this possibility in the mind always. Okay,
yes,
and this may manifest as you said rightly, like an ARDS, but in clinical situation, intraoperative phase, it is very difficult to take an X-ray and see whether there is a patchy opacity and all that. But what is the clinical presentation you will see rarely occurs?
Sir, decreased saturation, sir. Arterial oxygen. In ABG, we can look for arterial oxygenation.
Through the tube, will you get something through the endotracheal tube?
Secretion.
Secretions mimicking pulmonary edema. It will always produce a non-cardiogenic pulmonary edema because of the why non-cardiogenic pulmonary edema? What
So
is the
this is because of the
ARDS and rally and all these lung injuries? Increased permeability of the
Pulmonary.
alveolar capillary membrane.
Yes, sir.
So patient, even though cardiovascularly is a normal patient, they may have a non-cardiogenic pulmonary edema. There will be a lot of secretions. Bag will become tight, and as you secrete, you may have a frothy secretion coming out from the endotracheal tube. You have to make a diagnosis that it is TRALI and continue with a prone position ventilation with PEEP under 100% oxygen and maintain the patient with that. Right. What precautions to be taken before extubation of this patient?
So, before extubation, we should make sure the patient deliver tidal volume of 3 to 6 ml per kg, vital capacity of more than 10 ml per kg, respiratory rate should be less than 30 minutes, sir, and then negative inspiratory force more than 30 centimeter of water, sir.
Patient should be awake and conscious
Yes,
and
sir.
comfortable without pain. Okay, that's important. What are the post-op complications, likely complications, and how are they managed?
Sir, post-op pulmonary complication is more common in this patient, sir, like atelectasis, pleural effusion, pneumothorax, and post-op visual loss is also there, and neurological injuries, sir.
So, what are the causes of post-op visual loss in these cases?
Post-op visual loss due to the external compression on the eyes, pressure on the eye, prolonged pressure on the eye, which might cause a retinal artery occlusion, sir. Or there could be also ischemic optic neuropathy, which could be due to secondary to hypoperfusion, sir.
So these are the common questions that you have to expect in presentation. I'll just close this window and then try to show you a presentation on scoliosis, which might help you to have a visual impact on the screen visible now.
Yes, sir.
Okay.
Yes.
All of you have seen some time of other in your career patients like this with scoliosis. So the natural history, you have to collect ECG, history, examination, imaging, and specialist reference, severity of the curvature, skeletal maturity, clinical markers, decision making, do nothing, observe brace and surgery. So depending upon the corpse angle severity, sometimes you can ignore the mild scoliosis that will not cause any problem. Or you can observe the patient to see whether it is progressing and becoming more severe. And less than 40-degree angle can be treated by conservative methods like braces, and more than 40-degree with clinical symptoms or possibility of neurological injury, they require surgery. So these are all the decisions that have to be made once you see a patient with scoliosis. And the definition is a lateral curvature of the spine greater than 10 degrees, as rightly said, which is measured by taking a standing X-ray of the thoracolumbar spine. So it should not be a supine X-ray, it should be a standing X-ray of the thoracolumbar spine. You will take a PA view or an AP view.
PA view, sir. Lateral view.
PA view.
Lateral view.
For any cardiac ailment, will you take a PA view or for normal X-ray chest to see the heart and lungs? Do you take a PA view or a AP view?
PA, sir.
Normally we take PA view, sir.
So the whatever structure is closer to the X-ray plate, that will become more dominantly seen. That is why you pass the rays from the posterior, from the back towards the anterior for visualizing the cardiac and lung shadows. On the contrary, if you want to see the spine, it should be in AP view. The X-rays should be focused from the anterior aspect so that the spine vertebral bodies will be closer to the X-ray plate. Okay, so you have to take an AP view, not a PA view. Okay? And this is how the turning or the lateral curvature happens when the vertebra and the ribs are all involved in scoliosis. So it is a classification based on the region. Can be cervicothoracic, thoracic, thoracolumbar or lumbar, and or it may be a combined double primary. And classification based on the etiology can be idiopathic or congenital or neuromuscular disorders, neurofibromatosis, mesenchymal disorders, traumatic, etc. And how do you measure the corpse angle? Sometimes they may give you an X-ray and ask you to measure. So you draw a line from the upper body, upper surface of the maximum curvature, starting point of the curvature. For example, here it is starting at T12. So you draw a straight line from there and the curvature goes up to L4. So they have drawn another line from the bottom of the lower part of the vertebral body of L4. So the upper part of the vertebra of the starting point of curvature and the lower part of the vertebra where the curvature ends. You draw two straight lines and they cut each other to form an angle, and that is called the Cobb's angle. Another method is drawing a straight line from the midpoint of the upper line and drawing another 90-degree straight line from the midpoint of the lower line, and whatever angle is formed by these two lines, that is also called the Cobb angle. So you can measure it directly by the intersection of the upper and lower lines, or draw perpendicular lines from the upper and lower line and make them cut and measure the Cobb angle. And the person who described this is the person whose name is John Robert Cobb. And deformity, the questions that you want to ask are when it was first noticed, how it was noted, is it progressing, what are the treatment taken, whether any brace taken, any bracing done, or any prior treatment offered, and then whether there is any pain, because idiopathic scoliosis normally does not cause any pain. So if it is associated with pain, then there may be an underlying neurological pathology or a neuromatous disease. And any neurological symptoms, especially in angular hyperscoliosis, whether any gait problems, does the patient have difficulty in walking or loss of balance, and must ask for any cardiopulmonary problems. So these are all the questions that you need to do. And this is the way the whole thing looks when you see in the skeletal. You can see the whole spine is curved here, and the scapula here has come down, is rotated and twisted. The winging of scapula has happened here, and you can see the asymmetry at the shoulder level, and there is also asymmetry at the pelvic level, at the top of the pelvis. So that will cause the loss of balance. So history, can ask for birth history, developmental history. That is all very important in infantile or the juvenile type of scoliosis. And motor milestones, learning abilities are all very important in juvenile type. Then you can ask for family history, whether anybody else in the family is suffering, and past medical or surgical history, and any associated tangential anomalies like cleft lip palate, tracheoesophageal fistula, cardiac murmurs, genitourinary disorders. All these things also can be associated with this. And physical examination, you must examine the spine, then you must examine head-to-toe examination and neurological examination. And these are some of the common equipments used for that, to measure the length, to measure the straightness, goniometer, all these things. And this is a simple method of remembering. Look for the gait, posture, and spinal alignment, and skin and sexual maturity. Feel for any tenderness or step-offs and the stiffness in the paraspinal muscles. Ask the patient, move the patient to see the range of movement and flexibility, and measure the height and weight of the patient. Then look at the posture from the behind to see the line drawn from the back of the head to the sacral region, and it will be seen nicely how it is tilted. And spinal alignment also, you can make whether it is curved to the right or left, and what is the major curvature. So this is an example of how you can see this patient is not able to keep the left foot on the ground. It is lifted up because of the tilt here. So she is bearing weight mostly on the right leg. The back, the shoulder, these are all how you see that. And this is how the movements are measured, because these are all just for some knowledge to know how bad it is. And this is called the Adams forward bending test. It is mainly done to see the winging of scapula or elevation of the scapula. So you can see the rib prominence between a smooth hump and the elevated sharp hump that is happening in this forward bending. And lumbar prominence also can be made out. So these two things can be made out by this Adams test. And this is the frontal view, this is the side view of the patient. And Cobb's angle, clinical manifestation, less than 10 degrees, you won't have any problem. And more than 25, it starts getting the pulmonary pressures start increasing. More than 40, you have to think of surgical intervention. More than 70, there will be decrease in lung volume because of the narrowed the space in the thoracic cavity. More than 100 patients will have dyspnea on exertion. At more than 120-degree angle, there will be alveolar hypoventilation and chronic respiratory failure will ensue. So treatment can be non-surgical and surgical. The non-surgical less than 40-degree angles, then try braces, traction, and cast applications, all the things. And for surgical indications, it can be a simple posterior approach, or it can be an anterior approach, or it can be a combined anterior posterior approach. Now, what is the importance of knowing what approach is there? Supposing it is an anterior posterior approach, this is the special requirement that the surgeon may ask you.
Sir, in an anterior approach, we might require double lumen tubes. Sir.
Double Newman tip, very good. So you must have to collapse that lung, and you will have to do use the double Newman tube. So pre-anesthetic airway assessment is very important. Difficulties may be anticipated when there is an involvement of the cervicothoracic region. And supposing already some traction has been given as a conservative method, then you may have difficulty in securing the airway. Or patients with Duchenne muscular dystrophy may lead to tongue hypertrophy, which may cause difficulty in visualizing the glottis. And pre-anesthetic assessment of the respiratory system is very important. It usually causes a restrictive type of pulmonary disease with reduction in vital capacity and FRC. Severity, angle, number of vertebrae involved will decide how much of thoracic segments are involved, and that will give you an idea whether there will be respiratory restriction or not. Now, what is the conservative management? This is called application of the thoracolumbar cast, which is by Risser or Mehta casting. This is for infantile scoliosis, which can be corrected by the growing age. You can apply this. Always you can see there is a window given in the cast for the free movement of the diaphragm and protrusion of the abdomen after eating. If you don't give this gap, the patient will find it going for distress. So the back is completely covered. For an adult also, you can do the same type of application of metal cast also is available. And pre-anesthetic assessment, sometimes you may have to do pulmonary function test also, because reduction in the vital capacity is the first manifestation. And a prolonged period of hypoxemia results in pulmonary hypertension because of aggressive hypoxic pulmonary vasoconstrictor reflex. And they may go later on for hypercapnia and respiratory failure. And if you do surgery early, these changes in the respiratory system can be prevented. And infantile and juvenile is associated with true lung hypoplasia. So if this scoliosis occurs in very small children, you have to do an MRI and see the development of the lung. In those cases, the lung hypoplasia may be there, just like in congenital diaphragmatic hernia, where the abdominal contents have come into the thoracic cavity, the development of lung will be very much restricted. So, infantile and juvenile scoliosis, you have to make sure that the lung development is normal or not. And then pre-anesthetic, you can do a flow volume loop measurement, and you can see we assess the severity of restricted disease by the pulmonary function test, and see whether there is any decreased response to carbon dioxide stimulation. Neuromuscular dysfunction also has to be evaluated and documented properly so that we can differentiate whether it has occurred after the surgery or before the surgery. And preoperative instant spirometry is another way of improving this to some extent possible. And cardiovascular system, less common but more serious changes can happen, and it may be mostly secondary to the respiratory effect. by developing pulmonary hypertension and going in for right heart failure as stated. And detailed neurological evaluation is very important, and documentation also is very important, as I said earlier. And free of orders, you go for NPO, avoid a more strong opioids if there is a restrictive lung function. Can use bronchodilators, anti-syllables also has to be given, and you can use the regular proton pump inhibitors or H2 blockers as a prophylactic measure against acid aspiration syndrome. And anesthesia induction technique, most commonly do intravenous induction, go for general anesthesia. Use of succinylcholine are contraindicated if there is hyperkalemia because of myopathy or denervation, or patient has a possible history of malignant hyperthermia, or any central core diseases like Denborough central core disease or adenylyl cyclase kinase deficiency. So in such situation, you can go straight away for non-defibrillation block for intubation. And anesthesia technique, anterior approach to spine, you have to use a double lumen tube for lung insulation. Posterior approach, you can use a single lumen tube. And maintenance, a stable anesthetic depth is very important. Nitrous oxide narcotic inhalation agent or an intravenous technique may be used. So if there is no neuromonitoring, you can go for the conventional nitrous oxide narcotic inhalation technique, volatile anesthetic agent. If it is neuromonitoring is being planned, then you have to go for TIVA or TCI. And use minimum of neuromuscular blocking agents so that use the intermediate or low short acting non-defibrillizers so that you can reverse or get back the neuromuscular transmission to enable the neuromuscular neuro monitoring to be done properly. And regular monitor, blood gas, IV fluid should be warmed and kept. So there's a possibility these patients can go for hypothermia because of the large exposure of the operative site and the ambient temperature. And then positioning, because we have discussed to make sure. So you can see how nicely there is a gap in the abdominal region. The support is mainly on the upper thorax and the pelvic region. So the entire abdomen is totally free, and preferably the head should be in line with the thoracic spine with adequate support so that there is no hanging like this. And the arm is not abducted too much. It should be bent at right angles, and the dorsum is very close to you so that you can visualize. You can see a long pillow kept here to prevent pressure on the knees and the upper leg. Similarly, a roll has been kept here underneath the ankle joints so that the dorsum of the foot is not under pressure. And this is how all of you would be aware that how they are being turned. So this is the anesthetist standing here, 3 people, one holding the leg and then trying to turn the patient on. And some cases you have a support like this, but this will have a central hole. There's like what I told you in the casting, there will be a central hole for the abdominal movement. Otherwise, this is another way to enable C-arm to come in without any hindrance. So this is another way of support. And this is another what is called the jackknife position for some spine surgeries. And this is another way of supporting the patient in a huge paunch. You can see the patient's belly is so much, and there is a gap in the entire table so that the abdominal movement can be easily taken. And you can see the electrodes are all placed on the back, and this is surgery in the lower part of the spine. This is not scoliosis, but a regular spine surgery. And these are the dexmet propofol infusion for fever to maintain the anesthesia, for especially when neuromonitoring is planned. So you can avoid non-depolarizing muscle relaxant throughout by using this combination. And but if you are planning for TIVA, it is always a must you use this monitoring. I forgot to tell you. So it is always better to measure the depth of anesthesia if needed whenever TIVA is used. And this is the erector spinae muscle plane block. So we will perform that. So here you can see the ultrasound probe is being kept on the lateral part of the lateral to the mid spinous process. So you identify the transverse process of T8 and T9, and these are all the trapezius muscle, erector spinae muscle. So this is the plane just underneath that. So what they people usually do is go and hit the transverse process of T8 or T9, withdraw and locate the needle in the area below the erector spinae muscle. Okay. So that's how the whole thing is done. This picture may be sometimes given in the OSCE for you to identify. So please remember that. And the volume you have to inject is about 20 ml of local anesthetic under the fascia of erector spinae muscle. So this is how the whole thing is done. And this is another view from the cranial to caudal, TM needle, TP. This is the transverse process. So just above the transverse process, but under the erector spinae, the other muscles. This is another picture, please remember, which may sometimes be given in the OSCE also. And this is the anatomical picture to show how this works. So there is all the nerves are coming here. So this is the erector spinae muscle. And underneath that you have the transverse process. So in this area the spinal nerves are coming out. So by depositing the large volume of local anesthetic, you can work. So you have to do it on both sides. Whenever you want to do the surgery, you have to do the bilateral erector spinae block. These are the various, this is the support I showed you, where patient looks like lying fully on a support, but there is a gap in the center for the abdominal movement. And these are the other supports which are there. And normally there are names for that. Bolters showing arm position, and Montreal mattresses, and Jackson operating table, the Wilson frame. This is the common frame that is used, which is called the Wilson frame, and Andrew operating table. These are all various designs of that. So you have to protect the eye, keep the abdomen free, prevent compression of major vessels at the groin, avoid excessive affection of the upper limb, proper padding of all pressure points. These are the things that you have to take care, and cover all exposed parts to prevent hypothermia. These are the precautions. And just for the sake of those who have not seen or had an opportunity to see the spine surgery, this is the spine fixation with the Harrington rod. You can see the curvature exposure from the maximum curvature to the starting point of the curvature to the end point of the curvature. First the whole vertebral body, spine or exposed. Then the screws are fixed and then the rod is formed on that. And sometimes it is done on both sides. And he is the person, Paul Randall Harrington, who designed this. And these are all the screws that are put in the pedicle to fix the rod. And once you do the surgery, you can see the result, end result. The beginning picture, how the curvature is there. And once they have straightened it up, it has almost become vertical. Okay? So that is how the result is coming. And sometimes they may ask you about the arterial supply to the spinal cord. They ask you about this. Some of you may get the question as what is the blood supply, because we keep on repeatedly saying you should avoid ischemia to the cord. So that is lead to the question, what is the blood supply to the spinal cord, which is also important from anesthesia and part of angle, because we talk about the anterior spinal artery syndrome, this possible after spinal anesthesia in two cases. So it is supplied by two posterior spinal arteries and one anterior spinal artery, and they are arising from the posterior inferior cerebellar arteries, and they here they get supplementary vessels from at various levels, out of which this vessel, the artery of Adam cleavage, is very, very important at the thoracic level. So sometimes this vessel itself may be able to supply the entire supply. So make sure that the surgeon does not injure this particular branch, and this is how the whole supply goes. And the areas that is being supplied, what will happen if there is a ischemia, all that you have to read about. In spinal cord monitoring, you can do by what is called the critical zone areas from T4 to T9. And the goal of monitoring is to identify any disruption in nerve signals quickly so that surgical adjustment can be made on the table itself. It was in 1973, wake-up test was done by this person, Stagnara, and then can do the 2 or 3 switches on train of 4 to allow the patient to move the limbs. So if you have been using any neuromuscular blocking agents, you reduce the dose and time it, and use nerve stimulator to see whether the neuromuscular transmission is recovered, and then do the testing. That will be a better way to achieve good results. And the SSP and MAP, all that we have spoken about. So usage of volatile will try to delay the response. So avoid any volatile anesthetic agent. If at all you are using, don't use more than 0.5 MAC. And drawbacks of the wake-up test are requires patient's cooperation, and sometimes patient may suddenly jerk and move and fall off the table, and extubation also is possible. And it requires good skill on the part of the anesthetist doing it, and measure the motor function at the time of testing, but not continuously. So wake-up test should be kept as a last after completing the surgery. If you do it halfway through and then proceed with the surgery, sometimes you may cause a damage which will not be noticed. So it is better to do it as a, it is now confined only to where electrophysiological monitoring is not available, or if this method fails, or if they produce equivocal results. So these are the 3 situations where you have to depend on the Stagnara wake-up test. And this is how the motor evoke potential electrodes are placed for those who have not had an opportunity to use this for during the practice. So this is the SSP electrodes placed on the peripheral nerves, and this is how the tracings will be seen in the monitor that is used. So monitor display of SSP and MEP. And coming to blood conservation, will be 10 to 30 ml logs, the pre-allogenic blood transfusion to the minimum to avoid the risk. And methods of reducing blood loss, intra-abdominal pressure should be minimum. This is the first and foremost requirement. Then you can use hypotensive anesthesia, and you can use antifibrinolytic agents. And of course, you can use the vasodilators like NTG and SMP. And you can use the preoperative donation, acute normovolemic hemodilution, intraoperative cell salvage. These are the methods of conservation of blood. Post-op, they should all be kept in ICU for monitoring. The multimodal approach, the combination is very important. Paying epidural, though good choice, but most of the surgeons won't accept it because of the possibility of infection. And intrapleural infusions are also quite suitable if you want to avoid epidural. And postoperative visual loss is an uncommon complication. And causes can be ischemic optic neuropathy or central retinal artery occlusion, or cortical blindness. The visual cortex in the posterior aspect of the brain that also can be affected, and posterior reversible encephalopathy syndrome, PRESS. This is another common thing that may happen because of the blood vessel changes that happen. And pathophysiology, Because why they happen? Ischemia to visual pathways or major source of blood supply being affected, and mechanism: increased venous pressure, interstitial edema, rise in intraocular pressure, compression of vessels, hypoxia to optic nerve. Ultimately, it is ischemia and hypoxemia causing that. The risk factors are low postoperative symptom rate, presence of clinically significant vascular disease, long duration. So cardiopulmonary bypass is not being used here, but one of the conditions where it can happen in red cell transfusions and other blood components. Retinal ischemia can be central branch retinal ischemia, and in spine surgery it is very important here. So these are all the things that you have to remember with regard to scoliosis.